present, but it's a case of human diagnosis and created by Anand Patel.
Amazing.
And I will start.
Thank you, Amanda.
It's a 28 years old woman with metastatic breast cancer who develops alternate mental status overnight. Admitted with dyspnea 3 days, made NPO overnight due to concern in respiratory status, noted to be lethargic and slow to response to questions. And 1 minute to respond to questions. The following morning on admission, the patient was mentatic appropriately. So I will stop here.
Mukund, I can already tell that this is a mountain of data. So I think it's actually good practice for us out loud to say, what is your grasp of the foreground and what is your grasp of the background before we start to solve it? So gaining a little bit of clarity on the actual problem. So tell us what stuck with you in terms of the foreground and then the background.
Sure. So this is already, like you said, a really complex case. There's a ton going on. This is a relatively young person with a pretty severe background process of metastatic breast cancer. And the acute presenting concern is altered mental status, which has a vast, nearly unending differential diagnosis. But that's kind of the very broad starting point that I'm approaching this case from, thinking about altered mental status as the primary foreground concern and breast cancer with metastases as the background concern. And with regards to the foreground, of course, we have gone over the schema for altered mental status many times on VMR, but I really appreciate the MIST schema, M being metabolic, I being infectious, S being structural, and T being toxin mediated. In this person's case, I think malignancy factors in there somehow, although I'm not sure exactly how. And I think some causes of altered mental status, namely metabolic or potentially infectious, are more likely in this person than some other causes such as toxins, although there's plenty of information yet to discover, and I'm looking forward to seeing what else the case has to offer.
Yeah, I completely agree with you. I think that you nailed the foreground information and the pertinent background. And the question for you is, whenever you're analyzing the foreground, you want to have both the space and the time as something you're manipulating. So you got the space and articulated that out loud. How would you articulate the time course here?
In this case, it looks like we have a relatively chronic background process that's being complicated by a relatively acute foreground process. So
Yeah.
An exploration of the past medical history will help us understand if there are any predisposing factors to what has caused this acute presentation of AMS.
Yeah, 100%. I completely agree with you. I think that's the struggle that I'm having, quite honestly, just to name it out loud, is I'm not sure if this is acute altered mental status or hyperacute altered mental status, because Amanda has mentioned to us that the patient came in and was admitted for 3 days in the hospital for shortness of breath. And then overnight, she becomes altered. And I'm struck by that overnight. That seems to me more rapid than the traditional presentation of the acute MIST. Like if you think of the metabolic, the infection, and the toxin in particular, they don't usually present so acutely. So I'm struck by that hyperacute dimension. And I think in general, when you're operating in uncertainty about the actual time course, you should assume the more morbid one. And the more morbid one tends to be the more acute version. So here I would say, I'm definitely going to do the MIST workup because it's very possible, but I'm asking myself, how does my schema change if I actually commit to calling this hyperacute? And I think that hyperacute anything in general tends to be that there's something that was blocked, something was ruptured, or there was a discharge of electrical activity. That is a schema that you can use for hyperacute for almost anything. And there are some holes in it, but those are the most common causes. Something got blocked, like acute coronary syndrome or a stroke. Something got ruptured, so like a perforation, and then there was discharge of electroactivity. And practically speaking, for altered mental status, we have to wonder, does she have any of those things? Did something block or rupture? So did she have a stroke or a hemorrhage? Or did she have a discharge of electroactivity, namely seizure? And all of those are very reasonable hypotheses in somebody who has cancer, because cancer in the brain can cause hemorrhage, cancer in the brain can cause seizure, and cancer in the brain can cause hypercoagulability resulting in a stroke. So I think that the hyperacute dimension is very powerful here. I'm curious now, the hard question is, picture this. This patient is on your team. You're the soon-to-be MS3 who is going to see them, and they're fine for 3 days on your watch. Then they get confused. So the dimension to analyze here is the fact that she's been admitted for dyspnea. So if we assume that her dyspnea is pulmonary in origin, we don't know that yet. How might you connect somebody who has dyspnea and that then gets confused? This is a harder one, but let us know what your mind does with that.
The link between dyspnea and confusion. I think immediately what comes to mind is metabolic etiology of confusion, change in electrolytes or in pH. Potentially, if she's been dyspneic for a while, then carbon dioxide accumulating and causing hypercapnia related to altered mental status, that kind of a thing.
Exactly. I think the most common cause by far and away, if you tell somebody to make an educated guess about a dyspneic patient who becomes confused, the most wise bet is to say that they became hypercarbic. The problem with that hypothesis here is that the hypercarbia that most people have is from obstructive lung disease and COPD. She does not seem to have that with the limited information that we know. So we might have to entertain the more sinister kind of hypercarbia, which is reduced ventilatory drive, which can be common, which can be more common in the situation where opiates are involved. But the more morbid hypothesis might be that she actually has a brainstem issue in her brain, given the subsequent development of altered mental status. It's also not uncommon for people to get hypophosphatemic from dyspnea. The respiratory alkalosis increases phosphorus demand because of the work required for phosphorus to go in and make ATP, and patients can get encephalopathic from that for a variety of reasons. And then I will say that the final context to analyze this case is very rich. Is if we take the mist mnemonic, M-I-S-T, and say, well, what is the most common cause of mist as it develops in a hospital-induced encephalopathy? The most common cause by far and away is medications and toxins. So scrutinizing her medication list will be very, very important, as our two esteemed attending physicians just chimed in, Adam and Rebecca, emphasizing meds. Cool. Well, we've dissected this as much as we possibly can, I think, Mukun. So we'll see what Amanda has left in store for us.
So the past medical history is metastatic breast cancer and non-meds, non-family history, social history, and non-allergies. And in the physical exam, the vital signs are normal, lungs clear to auscultation, regular rate and rhythm with no murmurs, rubs, or gallops. So the patient was alerted and oriented 3 times, but answering questions more slowly, able to follow commands, no focal neurologic deficit. And there is a information that the patient had 7 liters of urine output overnight.
Oh no, go ahead, Amanda. Sorry.
I have some labs on admissions. I will say.
Thank
So
you.
the sodium on admission was 136. The potassium is 4.2. The chloride is 102. Bicarbonated is 24. BUN 17. And creatinine is 0.7. 0.7.
Could please tell me you predicted that Amanda would somehow tell us that this patient had 7 liters of urine output overnight. That's incredible. Um, I imagine that that is not something that you have spent hours and hours thinking about. So this is a good exercise in you kind of using analogical reasoning to come up with a list of possibilities that someone might have 7 liters of urine output. So tell us what your mind does with that.
Yeah, this is a fascinating situation, and I'm working a little overtime to try and put the pieces together, especially because the physical exam, the cardiopulmonary physical exam, is so remarkably normal, despite an admitting concern of dyspnea and the potentially hyperacute development of altered mental status. And then you've got this 7 liters of urine output overnight. So I think there are a bunch of possibilities floating around in my head, and I have no idea which of these are more rational than others. But I can start to think of it, at least first and foremost, by looking at, this person's in the hospital. I don't know what kind of medications they were prescribed while inpatient, but mistaken doses or medication mistakes might lead to all sorts of different presentations. So that's one possibility. The other possibility that you mentioned before is involvement of the brainstem or parts of the brain that might be leading to a source of dyspnea that has nothing to do with the lungs directly, but that might also be causing dysregulation of urine output. In particular, I'm thinking about some kind of a centrally mediated diabetes insipidus presentation. We have these labs on admission, sodium of 136, but presuming those labs are now nearly 3 days old, I would be really interested to see what this patient's sodium looks like after this episode of incredible diuresis.
Mukund, I think you hit the nail on the head. I think that where my mind is at is exactly where you're at. And my goal is just to simplify the process that you just walked us through. Polyuria equals either drinking too much water or you have diabetes. Hammer that home. If your patient has polyuria, they either are hydrating too much or they have diabetes, period. You have to be careful. Polyuria and urinary frequency are very different concepts. Here, we're lucky that we have the patient is not just urinating a lot in terms of amount, but a lot in terms of volume. So the question is this patient drinking a lot or do they have diabetes? We know she's in the hospital. And so Mona, I'll clarify I'm sneaking in a lot of things there. But thank you for pointing out Lasix. That sneaks into the schema. So you're drinking a lot or you have diabetes. Now, what kind of diabetes could you have? Two kinds, diabetes mellitus, which is very easy to check with a glucose or an A1C, or diabetes insipidus. There are two kinds of diabetes insipidus, central or nephrogenic. It turns out that nephrogenic diabetes insipidus is much more common because of medications like Lasix, which interfere with the resorption of water and cause a nephrogenic diabetes insipidus. There are other medications in addition to diuretics that can do it more chronically, like lithium, but acute is basically diuretics like Lasix. So as you said, we have to make sure she didn't accidentally get medications, which are the most common cause of nephrogenic diabetes insipidus. There's another really important cause to think about in general, especially in patients with cancer, which is hypercalcemia. And so we don't have her calcium here initially, and we really have to make sure that she doesn't have hypercalcemia as a cause. More likely, though, this is not nephrogenic diabetes insipidus absent a Lasix administration or diuresis administration. It's much more likely to be central because central tends to be much more abrupt and severe. Nephrogenic diabetes insipidus, again, absent diuretics tends to be much more indolent. So to solve this problem is actually very easy. We talk with the nurse about how much water she's drinking, get a point of care glucose, and then get a UA to look at the serum at the specific gravity. If the specific gravity is low, this patient has diabetes insipidus. That will tell us a lot. And yeah, I think we've made a lot of progress now. And as you're predicting, a hypernatremia is probably going to be the driver of the altered mental status. And so we'll have to solve the hypernatremia problem, but the glucose and the urinalysis telling us the specific gravity will be very, very important. All right, Amanda, tell us more, please.
So we have the BMP after being NPO overnight. The sodium was 144. The potassium was 4.1. Chloride 105. Bicarbonate is 26, 25. And BUN is 20 and creatinine is 0.9. In the next aliquot, there are the exams that will give us the final diagnosis. So I will stop here.
All right, what do you think, Mukund?
Well, the sodium has clearly gone up, but I don't know to what extent a sodium of 144 is capable of causing altered mental status, or to what extent the altered mental status would present. I'm still interested in, like you said, metastasis of a breast cancer to the bone, causing hypercalcemia, leading to the inhibition of ADH secretion or activation in the kidney, leading to some kind of diabetes insipidus is something to explore. Central diabetes insipidus maybe can be explored by a desmopressin challenge or something similar. I think I still want a little more data before I come to any conclusions. Like I don't think that the items we've talked about as being highest on our differential have really changed. But I also don't think this aliquot has confirmed any specific diagnosis for me.
Yeah, I completely agree with you. I think the only you have, since the patient has been NPO, you've ruled out excess water intake. Presumably that you would know the glucose by now. And when patients have an increase in their glucose causing polyuria, their sodium usually goes down as a result of the water being pushed into the serum by the glucose, attracted into the serum by the glucose, diluting the sodium, causing hyponatremia, which we talk a lot about, correcting the sodium for the glucose. So the fact that the sodium has risen so much so quickly, I will predict that the glucose is normal. So we are in the world of DI. And I completely agree with you. The question is this nephrogenic or central? And if you make some leaps by saying, well, I'm going to assume the patient didn't get a diuretic because she was NPO, didn't get anything, then central is way more likely than nephrogenic. The mechanism of breast cancer inducing hypercalcemia is often through bone metastases, and the lack of pain here, at least, doesn't eliminate the possibility of bone mets, but bone mets are usually debilitatingly painful in many people. So I think you can make some confident progress that this patient likely has central diabetes insipidus. Now, the question, Mukund, is a really hard one, but you're clearly latching on to the lead in this case. So let's prepare you for the worst case scenario. Say we do hold that hypothesis that this patient has central diabetes insipidus, and all of a sudden she becomes hypotensive, tachycardic, and hypoglycemic. What thoughts would cross your mind?
Hypotensive, tachycardic, and hypoglycemic.
Yep. This is going to help us think through why she might have central DI. So let's walk through that. So central DI, where do you think the lesion is in the brain when we say central?
Most likely in the brainstem, probably in the lower parts of the brainstem, maybe the medulla.
So you're close. It's definitely in the lower part of the brain, but it's in the hypothalamic pituitary axis. If you remember what ADH is made and secretes, so ADH is made in
in the
is it
posterior
coming back now?
pituitary.
Yeah, take it
Yes,
away.
it's
All right,
coming
tell us
back.
again.
Yeah, so ADH is made in the posterior pituitary, and you have a whole bunch of other hormones that are made in the
Yes.
anterior pituitary. So
Oh, I think you
maybe we're
latched on
worried about that involvement.
exactly. So what kind of endocrine hormone do you overlap most with as causing hypotension?
Cortisol.
Exactly. So why might this patient's sodium not be as high as we think it might be from pure central diabetes insipidus is because secondary adrenal insufficiency can actually cause SIADH, balancing the height of the sodium. So that's another clue that we're probably dealing with a space occupying pituitary hypothalamic disease process. So I'm really worried about this patient having a pituitary hypothalamic process. It turns out that breast and lung cancer are the most common causes of metastatic disease to the pituitary. I've seen a couple of cases of lung cancer do this. So I think that uh, the central DI hypothesis has a lot of weight, and there might be a subtle clue in the fact that the patient is not overtly hypernatremic. And you already pointed out this disconnect. She's not hypernatremic, yet she's confused. Why? It might be because she has a space occupying pituitary hypothalamic process, or this might be a warning sign of the impending development of adrenal crisis, which the lack of markedly high sodium is a clue to that. And part of adrenal crisis is actually developing an encephalopathy. So I'd be on guard for her getting sicker and ready to give her some steroids if she does. And in the meantime, I think that getting the urine data and the eventually the MRI, if it corroborates what we're thinking, will go a long way. Any questions about that, Mukund, or any other thoughts that you want to add now that we've let this simmer for a little bit?
No, that was great. That makes a ton of sense. I think my mind initially jumped to adrenal issues, but yeah, it took a minute to piece the brainstem pieces together, but that was great.
Yeah. All right, Amanda, tell us more.
So more exams, and we have a serum osmos is 288, urine osmos 78, and urine sodium is 20, and we have a specific gravity is 1006. And with these exams, we have the final diagnosis.
Yeah, I think Amanda, take us home. I think that Mukund latched onto this hypothesis early on, and since we're a little bit over time, why don't you tell us what happened with the case?
So, and the final diagnosis was insipidus diabetes. And given the patient's known history of CNS metastatics, the team was concerned about central diabetes insipidus. She was given DDAVP and her urine osmolarity rose appropriately, and she was ultimately discharged on the regime of the DDAVP, and which helped improve her polydipsia, and her sodium normalized. With treatment, her dyspnea present symptoms resolved, and on its own, an underlying etiology was not discovered.
Fascinating. Thank you so much, Amanda. Mukund, how did it feel to discuss that, and what are your thoughts on the case?
I had a lot of fun. I think it's a totally different experience thinking through cases on your own time versus thinking through cases in real time, and especially with so many eyes on you. But this is always a very supportive space, and I had a lot of fun today. I think this was a really good learning exercise and a lot of really fundamental medicine to be taught through this case.
Yeah, I couldn't agree more with you. I think that, you know, when you step on the wards for the first time, you can say, hey, no, done, I don't, when you're presenting to your attending or your resident, your intern, you'll be like, well, maybe this is scary and intimidating as it should be, but maybe a little bit less so since you've discussed a diabetes insipidus case publicly on YouTube and in front of all these people. I'm curious, McQueen, what are you most proud of?
I think stress level kind of melted away when we started talking, so I feel good about that.
That's awesome. That's I'm so glad to hear that. What do you feel like you want to focus in on and learn about after this is done? What part of this are you most intrigued about?
I think putting multiple pieces together with regards to endocrine regulation is still something that takes me quite a bit of mental processing time.
Yeah.
So that's something that, you know, if I see a string of symptoms that sound endocrine, it's worth putting the reps in to try and get those diagnoses to come out a little more fluidly.
100%. I couldn't agree more with you. I think it takes a lot of reps, and I look forward to hearing what you learned from them when we reflect on this later. Amanda, thank you so much for such an amazing case. Really, really appreciate you teaching us so much about this issue, about the many issues we talked about today. All right, Yasmin, take us home, please.
Wow, amazing, amazing job, McKinn. I definitely forgot that you were an M2. I like, as always, I really enjoy these discussions. Now, for the teaching points, our first approach was this chronic process was complicated by an acute process. We had to identify a possible etiology of AMS. We thought about, as we could think about toxicity such as hypercarbia or reduced ventilatory drive, the second one being a little bit more obscure. Now, other causes of dyspnea could have been medications given intra-hospitally. Now, found out this patient had 7 liter urine output, this polyuria. We could think, is she drinking lots of water, or she has diagnosis of diabetes? So we went to diabetes insipidus. Now, if it was nephrogenic or central, now, be caused by MET, especially lithium, and the central being more severe can be caused by brain tumors and metastasis, traumatic brain injury, and even pituitary ischemia. Anything that can damage pituitary gland can damage the secretion of ADH and cortisol. And to give us a little bit more of a suspicion of central diabetes insipidus, we have to look at the specific gravity. If it's low, we have to think it is actually central. Now, the breast cancer can induce hypercalcemia through bone metastasis, and breast and lung cancer are the most common causes of METs to the pituitary gland. And in this case, this patient could have had this AMS due to space occupying tumor, or she could be having an adrenal crisis. And well, the diagnosis was central diabetes insipidus due to pre-metastasis. And honestly, amazing case, Amanda. Thank you so much.
Oh, I love that recap, Yasmin. Thank you so much for doing that and for joining us despite having to study real hard for your upcoming exam. We really appreciate you. And thank you all for hanging out. Hope to see you tomorrow for RLR. We have a really special surprise for you. It'll remain a surprise. Your clue is that the time is unusual. It is actually at 12 p.m. Pacific, so 30 minutes from now, wherever you are in the world. I promise you, you want to join for this one. It will not be recorded because of how special it is. It has to be just a pure live experience. So really hope that some of you all can make it. Bye.